Let's see. Making sure I have the right one. Okay, this one is a 36-year-old female. She was diagnosed with Hep C about a year ago. She does have a history of IV drug use. She attended rehab, no longer going to meetings. She stopped drinking. She currently vapes. Trying to look at her actual chart to see the dates. She has depression, anxiety, and opioid dependence. Her exam was normal. Ultrasound showed fatty liver, and elastography was F1. She's currently on Suboxone, citalopram, buspirone, and vitamin D. She is immune to Hep A, and her Hep B vaccines were started. Overall, her blood work wasn't too bad. Platelets 263, AST 27, ALT 15. Vitamin D was 15, which I did start her on replacement. Her genotype is 1A, viral load was 40,000. Fibrosis biomarker was F0. APRI was 0.3, child is 5A, and MELD score was 8. I didn't identify any interactions for drugs, so would Maverick be the easiest choice for this one?
Thanks, Gary. All right, I'm happy to pull up the case again, and if anyone needs to refer back to it. But any clarifying questions for Gary about this case?
Hey Gary, it's Kaylee. Is she on any contraception?
Yes. She's not on pills. Give me 1 second. Sorry, I know I documented it. She actually had a hysterectomy.
Oh, okay. So yeah, you could definitely do Maverick for 8 weeks with her. The main reason why I was asking that was if she had been on any ethanol estradiol containing oral contraceptives, then Maverick would be contraindicated. But yep, you should be good to go with that one.
Oh, this was my easy one.
I love it. Thank you. Any other comments about this case for Gary? Feedback? All right, awesome. I'll pull up your second one now. Let's see. All right, are you good to do this one next, Gary?
Yes.
Awesome.
Give me 1 second. Let me just pull this count. So this guy, he is a 58-year-old white male. This whole story was very weird. He said he was probably infected with Hep C back in the 90s. He states he had several blood transfusions in 99 due to TTP. He reports no history of IV drug use. He does have several tattoos that he got from his friends in the 1980s. He also smoked marijuana back then, and he shared bowls and everything with people, but no actual IV drug use. He was treated in early 2000s with interferon. He states he was cured, but he never followed up after that. I cannot find records. I've tried everything I can. I cannot get these records. He currently smokes a pack a day. He uses marijuana continuously. He drinks socially maybe once or twice a week. Overall, his exam was normal. Ultrasound showed fatty liver. Elastography was F2. He has a history of COPD, stroke, obstructive sleep apnea, previous MI. And then he's on albuterol, fluticasone, Spiriva, and vitamin D. His BMI is 22. Labs, platelets was 265, ALT was 237, AST is 178. Vitamin D was 25. He is genotype 1B. His viral load was 344,000. And his fibrosis biomarker was F3. So help.
Excellent. Thanks, Gary. Any other comments or clarifying questions for Gary?
Was he in the military by chance? Just
Not that I know of.
Hey, Gary, did he get an ultrasound? Sorry, I missed that. Or an elastography?
He got the elastography. It was F2 and an ultrasound showed fatty liver.
Gary, with his Hep B serology, can you go back through that? I think I saw surface antibody reactive, but
So his core antibody was reactive. The surface antibody was reactive,
okay.
and the surface antigen was negative.
Okay, perfect. So he's natural exposure, but good protective immunity. So he's not somebody we worry about for flare. Okay. I'll let anybody else go if anybody else has questions, but otherwise I'll give a couple thoughts.
Not really questions, but definitely, I mean, he had some form of squirrely exposure there if he's got, Hep B and Hep C. Snorting, maybe, who knows?
Or
Tattoo.
tattoos. Oh, Gary, can he swallow okay? I know you mentioned stroke, like any residual symptoms. I didn't really see he's on any kind of like PO meds, maybe the vitamin D, but
Overall, he can swallow fine. He just
Okay.
has a slight deficit in his right arm.
gotcha. Okay. Yeah, I'll tell you, prior interferon treatment doesn't matter
Okay.
with our direct acting antivirals. We didn't know that when these medications initially came on the market, so we considered these patients treatment experienced. But now that these agents have been out for some time, there's more literature available with retreatment. It's really been shown that even if they've had prior interferon, whether they had to stop treatment early because of adverse effects or non-response, or whether they did successfully treat or complete a treatment course of interferon plus or minus ribavirin, even with the first generation protease inhibitors like cimeprevir, telaprevir, boceprevir, the old PIs, there's really no change in, or I should say reduction in sustained virologic response rates with the direct acting antivirals that we currently use. So good to go. So I commend you for trying to track down his records, because I definitely think it's important to clarify that. Sometimes patients don't remember what they took, or they'll just remember, hey, I took some pills, maybe a shot. It's sometimes helpful, even if you can't get the old records, to try to narrow down the time frame that they got treated. So if it was, early 2000s, prior to that, even prior to like 2014, I wouldn't worry too much that they've had any exposure to any of our current direct acting antivirals. So that kind of helps a little bit, I feel like, if you can't always track those records down. But yeah, I would just consider him treatment naive. I certainly think with his exposure history, he's probably had this infection for quite some time. He has some evidence already of fatty liver and some discordant biomarkers, but the fact that he's F3, I would go ahead and continue HCC surveillance every 6 months on this gentleman, at least for this foreseeable future. Also check an AFP, maybe if you haven't already. But with him, you really have several treatment options. It doesn't seem like, even with advanced fibrosis, that he has any sort of decompensation. So really your treatment choices for him being genotype 1B, you could do Epclusa for 12 weeks. You could do Mavorite for 8 weeks. I would recommend, if you were going to use Harvoni, probably just to be on the safe side, probably 12 weeks. And then Zepitir, which we don't really talk about anymore. That's the one that treats genotypes 1 and 4. But we don't really talk about that one so often anymore, because if you have a genotype 1A virus, then you'd have to do that baseline resistance testing. with Zepatier, he's 101B, so you wouldn't even have to do that baseline testing. So you really have the whole gamut of options with him. With his insurance, it's going to be Epclusa or Mavorite, but just so you know, you have a whole world of options with him.
Okay. Thank you.
Thank you, Kaylee. Any other feedback or recommendations for Gary? All right, Gary, are you good to go to your third case?
Yes.
All righty, let me pull that up. Right, there you go.
So this one is a 69-year-old man. Somehow I have two patients that were treated with interferon. He was diagnosed in 2011 with Hep C. He was treated in 2011 for 6 months. I do have the GI note, one of them. Per that note, it said he was found not detectable after treatment, but he relapsed. They recommended 6 more months of treatment, but patient refused. Patient is a nurse. He's had several needle sticks over the years, but he was never tested for anything. He used IV drugs and shared paraphernalia in the 1970s. So I'm not sure when first exposure was. He quit smoking 6 years ago. This guy is an alcoholic. He continues to drink 4 to 5 beers a day. He absolutely refuses to quit, to listen to anything. He flat out told me he knows he's going to die from it. And I have nothing else to do with that one. I don't know where to go. He has hypertension, hypothyroidism, obesity, diabetes. He's currently on amlodipine, atenolol, and a multivitamin. The diabetes is a new diagnosis. He is not immune to Hep A. He was vaccinated for Hep B. We did start the Hep A vaccines. His platelets was 230, INR is 1.1, ALT was 82, AST is 106, APRI was 1.2, CHOP was 5A, and MEL was 13. He is genotype 3, 1.39 million viral load. His fibrosis marker is F3. His elastography was F2. His ultrasound showed moderate fatty liver with hepatomegaly and no lesions.
Thank you again, Gary. All right, any questions for Gary? All right, and anyone with some feedback, recommendations?
It's just a bummer of a case about his drinking.
Yeah. He's definitely resistant to anything. And
Is he interested in treating his Hep C, or does he have like just a desire to go out with liver disease, liver failure?
he said if it's anything like interferon, then he absolutely refuses. And I told him it's nothing like that anymore.
Good.
I had
good.
the conversation. We talked about it. I told him about the most common side effects, and he's agreeable, but he will not discuss his drinking.
Yeah, genotype 3, you got limited choices. I don't think he's cirrhotic yet. So no reason for pre-test, or I should say pre-treatment polymorphism testing. So you get, I didn't look at his medicines. So Kaylee or Rachel, feel free to correct me on that one. But obviously you got your Mavorite would be the quickest and shortest. And then Epclusa would be the other treatment option for pan-genotypic agents. He's just nothing. He's going to get more and more fibrosis over the years, and he already has some on some of the markers. So, probably continuing him with some form of HCC screening is valid as well after treatment.
Okay.
But it's a bummer. It's kind of the concept of a, almost neoplastic process. You're reducing one of his hits if you treat the Hep C, but obviously he's still going to progress, and sad things to follow.
I agree with John. I mean, unless he's really motivated for treatment, with him being 69 and already several risk factors for liver disease progression and complications, I don't know, it's a tough case because even if you treat as hepatitis C, you may not be actually making much of a difference with your clinical outcomes in this patient. His MELD's already 13. That was one thing I was gonna ask you was if you had his sodium, what was his sodium? Because that's the only reason I can think his MELD may be a little bit higher,
Let me open
which
this.
wouldn't surprise me if it's low. I mean, I'm sure it's on the lower end. You know, he certainly, it doesn't seem that he's cirrhotic yet, at least by the testing that we have available to us. But if his MELD's already 13, you know, his prognosis is not spectacular long term. Anything kind of higher than a MELD of 12, I kind of like to just loop in GI and at least try to do it early if he's agreeable, because he has so many risk factors for liver disease progression. You know, he certainly wouldn't be a transplant candidate, even if his MELD were 40, because he's still actively drinking. But it is kind of one of those things that sometimes I use the MELD, you know, as a prognostic tool with the patient to show them like, this is where you're at right now, and you know, this is where you're going to be if this continues. It may not, you know, it doesn't seem like he's very receptive, but I probably wouldn't push too hard for his hep C treatment unless he demonstrates that he's really engaged in any other aspect of his health, to be honest.
Okay. I mean, every time I see him, I'll just continue on the trying to get him to stop. It was definitely, it got awkward in that room very fast.
I'm sure. And it's one of those, you're talking to a 69-year-old gentleman who's probably been drinking his whole life. And yeah, no, you know, he kind of already knows where he's heading. But I guess it's our role to kind of keep harping on that. And maybe we can make a change. But yeah, I mean, I would offer at the very least to see if he'll be agreeable to seeing GI to maybe further help stratify his risk, and maybe they can kind of be another source of engagement for him.
Okay.
But thanks, Gary.
Thanks.
I hate to say don't treat people, because that's usually the opposite of what I think, but I just don't know if it's going to be very helpful to him if he's not particularly motivated.
I agree with that. I mean, I even brought up that, like, you're going to continue drinking, then kind of what's the point? And even his wife was in the room and she was jumping in too, like trying, like, please stop. And yeah, he's definitely resistant. Okay. I will continue trying.
Yeah, it sounds so tricky, but you're doing great. And I echo what everyone else is saying. You're doing a great job. So thank you all so much. Any other questions, comments about any of the 3 cases that we just reviewed? Everyone's welcome to chime in.
Gary, I wonder if with that gentleman, I mean, maybe next time you see him, just ask him what I mean, if he's coming to see you, there's a reason he's showing up to his visit. So, I mean, maybe ask what his goals are, like, you know, what he really wants you to work with him on, because, you know, I don't know, maybe there's something that that he hasn't disclosed yet, and maybe helping him kind of recognize and set his own goals will help promote his health in a more positive fashion.
Yeah. Good point.
And Gary, did you have any other comments or questions about your cases?
No, I'm good. Thank you, everybody.
Awesome. Well, thank you. We appreciate you bringing the cases today. All right, Kaylee, we will turn things over to you now. I'm happy to share screen if you'd like, but I know you have John's office too. So if you prefer doing it on your end, I can make you co-host as well. Just let me know.
No, I'd like you to go ahead and
Absolutely.
pull my slides for me. For some reason, I was trying to pull them up from a different computer. It kept pulling up as like a PDF.
Oh, really?
So
No, I
I just will have you do it.
Yes, I am happy to.
All right, so whenever you guys are ready, I'm going to be talking about hepatitis B and hepatitis C co-infection today. I gave this talk a couple years back. It's actually been a while since I gave a didactic at all, but you know, this is something that I feel like we talk about a fair amount, but not really in detail. So hopefully I can kind of clarify some things today. But feel free, you know, at the end, I'll reserve some time for questions. We're going to have plenty of time, and I'm happy to answer those for you. We can go ahead and advance to the next slide. So objectives today are to review the transmission modes of hepatitis B and hepatitis C, to discuss the viral interaction and concept of a dominant viral hepatitis, describe the clinical features and outcomes of hepatitis B and hepatitis C co-infection, compare the impact of treatment on the coexisting virus, and provide an overview of how to manage Hep B with Hep C direct acting antiviral therapies. Next slide. So both viruses have shared modes of transmission. Both are bloodborne pathogens and highly transmissible parenterally. Hep B is actually 5 to 10 times more infectious than hepatitis C through blood transmission. Hepatitis B virus, however, is not only found in blood, but also mucosal secretions. So really anything, essentially all bodily fluids besides stool, saliva, semen, sweat, tears. And so it's much more efficiently passed both sexually and vertically than hepatitis C. Sexual transmission, if you recall from our sessions, we sometimes bring up that sexual transmission of Hep C overall is very low. It's less than 2%, and that's looking at heterosexual contacts. It's a little bit higher in individuals or men who have sex with men or HIV co-infection. Hepatitis B, actually cases in the US are primarily spread through sexual contact. So when we think of HIV being highly transmissible through sexual contact, hepatitis B is actually 50 to 100 times more infectious through bodily fluids than even HIV. However, we are also seeing trends of new acute hepatitis B virus associated with injection drug use really since the early 2000s. And so we often, even in West Virginia, we rank pretty high up there for acute cases of both hepatitis C and hepatitis B. You might recall, you know, Hep C transmission vertically occurs about 6% of the time. With hepatitis B, vertical transmission from mother to infant, if they have active Hep B and without any mitigation strategies whatsoever, can actually be up to 90%. With mitigation strategies, and by that I mean vaccination of the infant, treating the pregnant mother, IVIG administration to infants, you're really reducing vertical transmission by over 95%. So the risk will really remain highest if the mother has active hepatitis B, meaning detectable or high Hep B viremia during pregnancy, or a positive Hep B E antigen. Of that less than 5% that would still vertically acquire hepatitis B, if she has kind of those characteristics, 70 to 90% of vertical transmission would still occur. If the mom has low Hep B viremia or is Hep B E antigen negative, it's less than 40%. Also, you know, dual infection, it's which is why we're talking about today. It's common in highly endemic areas and among those with high risk of parenteral infection. So that's why we're talking about it in Echo Hep C, because we see serology a fair amount of time for both. According to the National Health and Nutrition Examination Survey, about 25% of people that have chronic hepatitis C in the United States actually have positive Hep B markers as well. So bottom line is really always test for concurrent viral hepatitis, which we know that. Next slide. In terms of viral interactions between hepatitis B and hepatitis C, patients with the combined Hep B, Hep C co-infection really exhibit a large spectrum of virologic profiles. We don't really know the specific virologic and molecular interplay of co-infection, but it's likely due to a mix of the host's immune response as well as viral competition for the host machineries involved in replication. What we do know is that hepatitis C usually exhibits domination. And that explains that phenomenon of why we often, when we're talking about what Hep B serology did you check, we always want to know if you were checking the Hep B surface antigen and antibody, but also the hepatitis B total core antibody, because it's really that isolated Hep B core positivity or serologically silent occult Hep B infection that we're referring to. So why is Hep C dominant? It's suggested that it's because there's certain proteins of the Hep C virus that actually inhibit Hep B viral activity and impede the function of Hep B polymerase, and that suppresses Hep B viremia. There's also cases where Hep B is the dominant virus, but we tend to see it more often that Hep C kind of dominates. That's also why whenever we are treating hepatitis C with our direct acting antivirals, we always warn if there's Hep B co-infection, there's that risk for flare. Spontaneous clearance over time of one or even both viruses definitely can occur. We know that underlying chronic Hep B infection is actually a protective factor for spontaneous clearance of acute Hep C infection. It can actually happen over 40% of the time. Excuse me, in individuals with chronic Hep B and Hep C co-infection, sometimes we even see spontaneous clearance of hepatitis B surface antigen. And that can even happen about 2% per year. All right, next slide. The clinical features of hepatitis B, Hep C co-infection. So simultaneous acute hepatitis with both viruses is actually very rare. Typically you see a superinfection, so you already have one virus and then are exposed to the other and become infected with the other. In terms of clinical features, the acute clinical features are really comparable to monoinfection, where you see that serum thickness followed by jaundice, dark urine, light stool, nausea, vomiting, sometimes fever, and that can last sometimes longer, a month or longer. In most cases, however, we don't really diagnose Hep B and C in the dual infection in the acute phase. It's really diagnosed in the chronic phase. Chronicity rates are comparable to rates of monoinfection. Again, you do have that small increase in likelihood of spontaneous clearance, but overall we don't see it super often. And fulminant hepatic failure is higher with superinfection than monoinfection, but it really still occurs just in a minority of the cases. Again, why we always vaccinate for hepatitis B and Hep A, but why we vaccinate for Hep B in all of our Hep C positive patients, because there's, again, that increased risk. Next slide. In terms of clinical outcomes, so there's really conflicting data as to how much the degree of liver damage is really compounded by co-infection. Some studies estimate that the risk of necroinflammation leading to advanced liver disease could be increased up to threefold. A few studies have said there's really no difference in liver disease severity, whether it's monoinfection versus co-infection. The consensus, though, really seems to point towards there is increased severity of liver disease in co-infected patients. The takeaway would really just be that even though that degree of damage can be quite variable, each virus is going to exert its own pathogenic role, which can be unpredictable and can cause a cumulative effect on liver injury. In terms of development of hepatocellular carcinoma, it's a little bit more well-defined. We do see clear synergism between hepatitis B and hepatitis C carcinogenesis and the development of HCC. So remember, with hepatitis C monoinfection, there's about a 1 to 4% risk of developing HCC per year, and that tends to happen once cirrhosis has already been established. With hepatitis B, you see monoinfection, you see liver disease progress at a much faster, unpredictable rate. HCC can develop really at any stage, even in the absence of liver fibrosis. And individuals that have chronic Hep B have a 25 to 40% lifetime risk of developing liver cancer. So it's a little bit different in how we conduct HCC surveillance. It's really stratified based on certain characteristics, like how active the hepatitis B is, the degree of Hep B viremia, or how high their ALT is, if they have a family history of HCC, if they're Asian or African descent, more advanced in age. And that's because those groups in particular are stratified at having a higher incidence of HCC. However, if you have co-infection, the cumulative risk is really going to depend on the Hep B replication status. So if you have co-infection but undetectable Hep B viremia, really the HCC risk is equal to Hep C monoinfection. If you have Hep C co-infection and active Hep B replication, there's twice the risk of hepatocellular carcinoma and a much higher increase in mortality compared to latent Hep B infection. And that's really because hepatitis B oncogenesis is driven by that X protein, which really supercharges that progression and development of HCC. So bottom line, again, is really co-infected patients that have known or suspected advanced fibrosis or cirrhosis should really be followed regularly, probably every 3 to 6 months with imaging and labs. And that would even be after you treat hepatitis C if they do still have active Hep B infection, and even despite Hep B virologic control. Think of it as the histologic changes to the liver have already been established, and those really precede a neoplastic state. Next slide. So really the most efficient strategy to mitigate the risk of HCC development is going to be viral eradication of Hep C and virologic control of Hep B. Treatment considerations and treatment goals are very different between these two viruses. Remember, the goal of HCV therapy is cure or sustained virologic response through the use of direct acting antivirals, or our DAAs. The goal of Hep B therapy is virologic control, and this is really in the setting of clear-cut treatment indications through a very well-defined treatment algorithm. So you only are treating Hep B in very certain circumstances, really, because when you start someone on hepatitis B treatment, the goal is not viral eradication, but viral suppression. If a patient, and most of the time is a lifelong commitment, if you stop this patient's Hep B treatment or they decide to stop, they run a very high risk of reactivation. Where Hep C, it's very short course of treatment with true eradication of the virus. Next slide. What about the impact of treatment on the coexisting virus? So this is, if you're going to take anything away from this session, this is where I want you to pay attention, because this is very serious. So hepatitis B reactivation during and after HCV therapy with our direct acting antivirals is what we harp on every session. That's why we always want to know that full Hep B serology. Hep B reactivation with Hep C therapy can kill patients. And so the US Food and Drug Administration issued a drug safety warning post-marketing in which they identified 24 cases, confirmed cases of Hep B reactivation in individuals receiving DAA medications. And then by the time the data was published, there were 29 cases. The severity of the hepatic damage ranged from silent Hep B reactivation, as evidenced by there was no viremia at baseline, and then they now had elevated viremia without any clinical hepatitis, to fulminant hepatic failure requiring liver transplantation, and then 2 deaths were reported in these cases. So clinical events were more common in individuals who had a baseline detectable Hep B surface antigen, and much lower in those who had hepatitis B core positivity that was isolated. In 29 case reports, there was actually Hep B serologic data that was missing. So we didn't know that this would cause flare, and so we're always really checking for co-infection. The other thing to note is this was regardless of which direct acting antiviral was used. And it typically happened about 4 to 8 weeks after initiation of our DAA agents. Next slide. So now it's a black box warning. So if you look at the prescribing information on any of our direct acting antivirals, you're going to see this. I just copied and pasted this black box warning. It's basically saying if a patient has current or prior exposure to hepatitis B, there's a risk of flare, and that all healthcare providers should screen for Hep B at baseline and monitor for Hep B flare or treat hepatitis B when indicated. Oh, and why does this happen? Again, we talked about this kind of briefly in the few slides back, but we can just presume that the reciprocal inhibition of hepatitis B that was previously superimposed by the Hep C dominance, once that's removed because Hep C viremia is getting cleared with treatment, now Hep B is becoming that dominant virus. Next slide. So after that initial statement was issued, a systemic review and meta-analysis was published, and this was in 2018, that really showed clinically significant Hep B reactivation was most frequent in patients with detectable serum Hep B surface antigen at baseline. So 24% of the time that reactivation occurred, it was with detectable Hep B surface antigen. It was very rare in patients who had isolated Hep B core positivity, so happened about less than 2%. It was about 1.4%. And the risk of Hep B reactivation related hepatitis was 9% in patients that had chronic active hepatitis B infection. No clinical reported hepatitis or no clinical hepatitis was reported with baseline isolated core positivity and undetectable baseline DNA. The other thing that I thought was interesting, or this is kind of surprising, was that the risk of Hep B reactivation or even clinical Hep B hepatitis was really not significantly higher in patients with cirrhosis versus patients without cirrhosis. Yeah, so I kind of was a little bit surprised about that. Next slide. So really, to stratify your risk of Hep B reactivation during and after DAA therapy for Hep C, we obtain full baseline hepatitis B serology. That includes our hepatitis B surface antigen. That tells us if how active, if this is an active infection. Our anti-hepatitis B core antibody, and this is the total antibody, not the IgM, that tells us if there's any history of Hep B exposure. And then we also check our anti-hepatitis B surface antibody, which is our marker of immune control. Next slide. So what are our Hep B treatment recommendations? So what do we do when somebody does have a Hep B surface antigen that's positive or has active Hep B? It really varies upon which guidance you're looking at. So the European Association for the Study of Liver Diseases, in 2017, that's the last time their guidance had been updated. They actually recommend that if you have Hep B surface antigen positivity, regardless of the level of Hep B viremia, you should prophylactically treat the Hep B until 12 weeks post DAA therapy. If you're looking at the American Association for the Studies of Liver Disease guidance, it states you don't really have to treat if you have just a Hep B surface antigen positive, but you will just treat based on the ASLD chronic Hep B guidance. So you'll monitor your ALT and Hep B DNA every 4 to 8 weeks while they're on Hep C treatment, and then still continue to monitor 3 months post DAA completion, but you don't actually treat unless they meet the specific treatment guidance for Hep B. Now, the Asian Pacific Association for the Study of the Liver, their guidance states to prophylactically treat all patients with Hep B co-infection who have advanced fibrosis, cirrhosis, or prior history of HCC, and you'll treat them until at least 24 weeks after DAA completion. If they don't meet that criteria, then you could consider prophylactic treatment or closely monitor them. Next slide. So then I put in my opinion because there's a lot of guidance to look at and to consider. I tend to kind of lean towards the AASLD guidance, but I just wanted to kind of take a couple slides and kind of go through my thought process of how I would approach patients that have positive hepatitis B serology. So if you have a patient that only has a hepatitis B surface antibody that's positive, core negative, surface antigen negative, this is your safe zone. Go ahead and proceed with DAA treatment for Hep C. You don't need any additional monitoring. They're not at risk. Those patients aren't at risk for flare at all. Okay. If you have a positive hepatitis B core antibody, so they've been exposed to Hep B, their surface antibody is negative, so they don't have good immune control. Their surface antigen is negative, so they don't have evidence of active infection. That's what we consider that isolated Hep B core positivity. In my my practice, I check the baseline Hep B DNA. I also check the pre-core Hep B E antigen and Hep B E antibody. If baseline DNA is not detected, I monitor their transaminases every 4 weeks while they're on Hep C therapy. If the AST or ALT values increase from baseline, then I check a Hep B surface antigen and repeat a quantitative DNA level for Hep B. That's a cost-saving measure, or I guess the other thing would be if any patient reports any signs and symptoms of clinical hepatitis. If my baseline Hep B DNA is detectable, then I would consider prophylactic treatment if they already have underlying advanced liver fibrosis or meet the Hep B treatment criteria. And there, if you even just Google AASLT, chronic Hep B treatment guidance, it's very algorithmic as to who qualifies for treatment and who doesn't. Next slide. If the patient has hepatitis B surface antigen positivity, again, I'm going to check my baseline Hep B DNA and the pre-core. I go ahead and prophylactically start hepatitis B treatment to prevent reactivation, preferably 2 to 4 weeks prior to starting Hep C treatment. And then I continue them on hepatitis B antiviral therapy for at least 3 months following DAA treatment completion or SVR12. And that's really because, again, that risk of flare continues even after DAA therapy has been stopped. If you're going to stop Hep B treatment at that time, continue to monitor for Hep B flare. Next slide. What about the other way around? So what about your patients that have chronic hepatitis B that need treatment that have Hep C co-infection? So what does Hep B treatment do to hepatitis C reactivation? So with the opposite, with Hep B viral replication, when that's inhibited by antiviral therapy, a reactivation of Hep C infection is also possible, but it doesn't really matter. It's not really clinically significant. There's nothing that we really do. You just monitor the Hep C as you would otherwise, or treat the hepatitis C. So it's really the Hep B reactivation that we get concerned about in terms of harming our patients. With an increase in Hep C viremia, there's just not any clinical significance that's been demonstrated so far. And next slide. And then those are my references. CDC has a good, I think it's like a YouTube link. If you wanted to actually go through, it's just a few minutes to review the hepatitis B serology itself, because sometimes that can get a little bit confusing, especially when you're considering like the pre-core mutants and whatnot. But really, I mean, it seems convoluted and confusing in terms of Hep B guidance for reactivation. But it's kind of one of those things that once you see it and get a little bit more comfortable, it's not as difficult once you're actually doing it than it sounds when somebody's just talking to you about doing it, if that makes sense. But that's all I have. Do you guys have any questions or clarifications, anything?
Thank you so much, Kaylee. I missed your presentations. You always do such a great job, and I'll
thank
definitely
you.
be sure to distribute your slides so everyone has.
Thank you.
Yeah, of course. I will read a few comments that were in the chat. So Dr. Bailey, I think, had to hop off. She was saying they're putting me to work, but said good to see
No.
you today. And then Jen Boyd actually also had to hop off for another meeting, but she was saying great didactic and timely for me, as I just submitted a case of a guy with Hep B and his Hep C resolved spontaneously. So she's looking
Oh,
forward
cool.
to discussing that. Yeah. That's
We'll look
awesome.
forward to going through that case. That'll be good.
I know, I wish they were able to hop on here again, but I'm sure she submitted the case. So next time we'll definitely be able to talk about that.
Awesome.
Anyone else with comments, questions? That's super helpful. I feel like we never really discussed too much about hepatitis B, so it's nice to get that refresher too.
Hep B can be a little bit confusing because it's very, I guess treatment is overall fairly straightforward because it's so algorithmic, but I feel like in our echo sessions, when cases are presented, we kind of just tell you, hey, look for this and make sure it's not there, but we don't really talk about what to do if it is there because we don't come across it too often.
Yeah, that's a great point. And I think Dr. Bailey actually, talking about not coming across certain things often, I think Dr. Bailey submitted an HIV case for next time as well. So that should be interesting.
Yeah, that should be very interesting. Any Lyme cases so far?
No Lyme cases in, but we should be, I think one tactic we can do is just reach out to some folks who submit cases and see if they have Lyme patients. So we can just walk through it with them. Because I'm sure everyone's seeing some patients with Lyme, you know, so.
Thank you guys.
Thanks, Kaylee. We really appreciate you. We missed your presentation, so really, really grateful for you.
Always good to see you, even though you're glitchy.
I know.
I was glitchy today too. I don't know why.
I know, we're twins. I don't know. I gotta figure this out. It's been doing it for a while, but I'm sorry if it's like a little epileptic. But
no, it's fine.
Okay, well, the only announcements I have is Kaylee, you're up again next time to present on April 27th, and we have down management of HCV treatment interruption. So if you need to tweak the presentation in any way, like title or topic, you're more than welcome to, but that's what we have down for now. So we look forward to seeing you all next time. Thanks, guys.
Thank you guys. Take care. Have a great week.
Bye.
Enjoy the beautiful weather.
Yes, you too. Bye.